All right, I'm Dr. Jeff Clement. Welcome to the second part of our healthcare payment systems and reimbursement model module for PA 708, Business of Healthcare. In this second part of the module, we're going to be talking about how the system has tried to move from just providing a large volume of care to actually delivering value and health for the population. So even today, still, fee-for-service is the dominant payment method. So what does that mean? It means that for every unit of care that's provided, there's a payment associated with that. There's not necessarily any outcome link associated with that. And that means that the incentive for the practice is do more care, right? Like volume equals revenue. So in module 6, we'll talk in some detail about how these per units, relative value units are calculated and the dollars that are associated with them. This is still incredibly relevant, in particular for PAs, as we'll talk about in that module, both how maybe you get compensated and definitely how your organization gets compensated. And there's a lot of decisions about how PAs should practice, especially under a fee-for-service model. But going beyond just PAs, it goes across the population and the delivery model, and in particular that idea of no outcome link. And so I think we've all experienced that. Like you go, let's say, to the car wash, and they're like, oh, you want to add this add-on? Do you want this little this that? Do you want this this extra boost power wax wash? Right? If you go to buy a car, the dealer's going to try and throw in all. You want the paint protection, right? Why are they doing that? Why do car dealers sell you the paint protection, right? Whether or not it actually does anything, I'm not convinced it does anything. Why do they do that? Because it's an added service that there's a fee associated with, and they get some money, right? And there is evidence that this happens in healthcare too. It's a bottom line again, and I know we all want to be focused on the care that that our patients get. And we're not trying to sell them add-ons, but things happen and people make decisions. And again, we're talking like on average, system-wide, there is evidence that people get more care, maybe that they don't need, when there's no outcome link associated with it. All right, so this is a study, 2017, but there's many like it across different care settings. This is it's another interesting one. It's another one on the military. Again, there's a surprising number of studies, especially in health economics, related to the military population. And that is because there's a couple reasons. One, you just have really good data. And tracking some of these folks, you have incredible data, longitudinal data for years. And so like in my own case, because my dad was in the Navy and then I joined the Marine Corps, and it's all an integrated health system. There, my medical records covered from when I was born all the way until I left the military, and I was like 29 at the time. And so, if you look at most like health registries, especially on the insurance side, patients are typically covered, like again, on average, for like 5 to 8 years. You do not often have, 29, 30 years of coverage for people. And again, like this was not like just, they're just like the military folks. Like, no, like I was a kid, and I was hospitalized and all the other stuff that happens to you as a kid. My mom, all of the pregnancies that she had, any health issues that she had, that's all in there. And as military retirees, and both of my parents were in the military, and so the military, like the data that they have is just really good. So on my parents, there's like 60 years of data on like at the individual encounter level, like 60 years of data, and all the paper records are digitized, like going all the way back to the 80s and 90s. It's pretty. Anyway, so that aside, that if you're wondering like why there's so much stuff on the military in the health econ space, this is why. They also they do make this. They have a mandate to make this data available in ways that say like United Healthcare doesn't. So if you're a health economist and you are interested in studying some of this stuff, you can, obviously there's a process, but you can get access to all this military data at the encounter level by patient. United Healthcare is not going to give you that. And if they do, they don't have 60 years of data on their patients, right? So that aside. Okay, so what did this study look at? This study looked at lumbar spine disorder treatment. Okay, and so you could do various like discectomies versus like much more aggressive lumbar fusion, right? And with back surgeries, especially, more is not necessarily better, and more aggressive treatments do not necessarily work, even though they're much more expensive. Okay, so this study, you got to have a little bit of insight into how the military pays for healthcare, provides healthcare to military service members and their dependents. So some of you, I know you're well familiar with this. Other places or other folks maybe haven't seen this. Okay, so if you're in the military, you're on active duty, or you have you're in the reserves and you have TRICARE insurance, then the military is paying for your healthcare, generally with no copays. It's a nice benefit. And again, like, experiences can be mixed, depends on where you are and what's going on, and like I have my thoughts on that. Overall, it's very high quality healthcare. Military doctors are they're great. Sometimes I do think there could be more competition, and competition can be a good thing. There can be long waits for care. That was my experience. I hear in some places it has gotten better, but anyway, neither here nor there. Okay, so you have this coverage, right? And the folks who are stationed on or near a large military base are generally supposed to, and it's gotten a little more flexible, but generally they will go onto the military base and go to the military hospital. Okay, so you'll go to the military hospital, and the folks there, they're all salaried. A lot of them are on active duty themselves. So if you go to, in DC, Walter Reed, Bethesda. So there was Walter Reed Army Hospital and Bethesda Naval Hospital. Now they're just one giant medical center. And there's a couple other military hospitals in the DC area, just because there's so many military folks. Portsmouth down in near Norfolk, near the naval base. You have Camp Lejeune down in North Carolina. You have Fayetteville with Fort Bragg. You have Camp Pendleton out in California. You have, so anywhere you've got a big military population, they're going to have a big hospital on the base, and they're going to do all the stuff. And it's going to be either active duty service members, in uniform, doctors and PAs and nurses in uniform. They get their salary every month, just like everybody else. Doesn't matter how much work they do or don't do. They don't get paid more, and nobody is breathing down their neck to do more work, to jack up revenue. In other places, there is not, a military hospital anywhere nearby, but there are active duty service members. Here in the Twin Cities, we do not have a military hospital, right? This is separate from the VA, obviously like related, but the VA does not provide the coverage for the folks in the military. So there's not a military hospital here because we just don't have the volume of service members, but we do have plenty of active duty service members here in the Twin Cities. For example, all of the military recruiters who, are here. We have folks on active duty who are doing stuff related to the National Guard. We have some active duty folks doing stuff related to actually on the university campuses for the ROTC programs. So all those folks are, the military is paying for their healthcare through TRICARE insurance. They're going to mHealth Fairview, to HCMC, to Abbott Northwestern, just like anybody else, and TRICARE is paying for their care. And so this sets up a really nice experiment where these people are very homogenous, right? Because it's basically pretty much random whether you got assigned to the Twin Cities for a few years or, and then next year you're going to be back at Camp Lejeune in North Carolina going to the hospital on the base, right? And so it's a very homogenous population. The average health of this population is very consistent, whether or not they, and it all happens to come down to where do you happen to be in your tour, in your career right now, right? And it's basically, and one of the complaints about the military is they don't really care what you think, and you pretty much get assigned more or less randomly. I mean, if we're being honest, it's not totally random, but there's a lot of randomness to it, right? And so you have people who are randomly, more or less, using basically a fee for service, where they go out in town and they go to whatever doctor, whatever hospital, whatever, and they get this. They have a lumbar back issue, or they go to the military base. And so where's all this going? What this study found is that in the DoD setting, salary DoD setting, where there's no income, where there's no financial incentive, 55% of the procedures were discectomies, as opposed to 39% of the surgical interventions in the fee-for-service setting. So discectomy is 55 and 39%, whereas so that's a pretty big, same patient population, probably the severity is pretty similar, and 15 fewer percent are getting a discectomy, and then you see almost exactly the inverse, where many more interbody fusions are being performed in the fee-for-service setting. So where's all this going? Basically, in the fee-for-service setting, people were the providers were incentivized to do the much more aggressive surgery at a much higher rate. And again, this is one study. You can find many more like it that find similar things in other settings, other clinical settings. Extra tests, we just always do, we just always check the CBC. Like, really? You need a CBC every time, right? Just adding on extra services, extra tests to be able to collect that extra income. And maybe it's a little more subtle. It's just upcoding, where they're this visit was more, we're going to up the complexity of this, right? And this enters in very subtle ways, where you might get a note kicked back to you and say, oh, you need to mention this, that, the other in your clinical notes, so that, why is that? So that they can bill your exam at the higher code to get higher reimbursement. So bottom line, fee-for-service pays for activity, not outcomes. So more visits, more tests, more procedures, all these will directly translate to more revenue. That's the incentive, right? And, but is the patient any healthier at the end? Maybe, maybe not. And so that's where we try to, the system is trying to move towards, connecting health outcomes to what is being paid for. So this brings in the idea of capitation. All right, so the idea is that, hey, we're going to pay a fixed per member per month rate to cover this population. All right, and so you have an organization and they agree, yep, we're going to cover all these people. And regardless of how much care they use, we're getting X number of dollars per month. If patients use more care, then the provider loses money. If the patients use less care, then the provider wins, and they get to keep the money. Okay, so it flips the incentives. So instead of, whereas fee-for-service, do more tests, do additional scans. Capitation actually rewards doing less. Okay, so no, don't do that. Don't look for that. And so initially you're like, hey, where's the risk? We'll talk about this, but the idea is to align the incentives towards prevention and appropriate care utilization. All right, so it also has the advantage of giving providers budget certainty. It rewards coordination of population health management. So, we want people to be healthier. We want to encourage things that are, maybe they have expenses up front, but in the long term are going to make people healthier. So Kaiser Permanente out west is sort of the canonical example. There's other examples in Medicaid managed health. You have global versus partial capitation. So the idea is that, hey, maybe parts of care, are easier to control than others. And so we don't want to make providers bear all the risk for all the patients for everything, but we're just going to focus on some parts of health and care. There's different ways to play this out. One of the big challenges in many areas is that the provider can't really expect to hold on to the patient long enough to reap the benefits of paying for extra care now. So what do we mean by that? Okay, so let's say that we identify that, hey, we've got a bunch of folks who are at risk for type 2 diabetes, and we want to get out in front of it, right? Because if we can get those lifestyle changes made in their 40s and we can start to monitor A1C, we can start to do all those things, then, long term, 20 years from now, we're not going to be, dealing with the devastating consequences of type 2 diabetes. They're going to be healthier. Everybody wins. We spend less money. They're healthier. What's not to love? Well, the problem is if we spend a bunch of money this year on A1C monitoring, and so they're like, I can't do that. I'm too busy. Hey, we're going to send out a community paramedic, or we're going to send out, a community nurse. We're going to do different things. We're going to provide some education. We're going to make sure you get your meds, whatever those things are, right? They're not going to reap benefits this year. You're not going to see any cost savings this year because, yeah, they're maybe on a path towards long-term health consequences, but those consequences aren't going to show up this year. So the savings aren't going to show up this year. And so Kaiser Permanente, on the other hand, they have such market share that they know that they're going to have those patients for decades on average. And they're willing to, invest in some of those things. One example there, they were one of the first health systems to sort of go in a big way on the hepatitis C treatments, whereas a lot of providers just wouldn't pay for them. Like they're like, no, this is a $500,000, $400,000 when they first came out. And it's like, well, we're not going to pay for that. And Kaiser Permanente is like, well, we'll pay for it because if we, we're going to be paying for a liver transplant 10 years from now if we don't, right? And then the patient's just really sick and needing a liver transplant and has had 10 years of terrible health that required all kinds of care. Yeah, we'll pay for that now. So having that long-term cost view is really essential for capitation to work. So what is the, how does this work ideally? What's the best case scenario? So this, I've pulled this paper. This paper, I specifically looked for something outside the US because I wanted to get at the, just the raw economic incentives. Okay. So like, what's the idea here? And we see that like, hey, this works. Asterisk, right? So this study looked at the influence of what happened when you had capitation for payments in a county in China, in rural China. And what they found was that the average medical costs for the type 2 diabetes patients went down. So a lot of the care in China, it's fee for service, and a lot of it you have to like pay up front. Like patients have to come out of pocket like a fair amount and pay up front. And so it was moving, towards more capitation and standardized care, and this coverage, and that there was increased standardization in prescribing practices, and you've got more comprehensive exams, testing, all that stuff, and increased medication prescription intensity, which like you're like, wait, so they prescribe more meds? But yeah, like that actually makes sense in this context where, in the past it was much more fee for service. Are you going to pay for it? Like, I don't know. Like it's a lot of cash pay, for example. And now, especially like early stage type 2 diabetes, you need to be, prescribing metformin, prescribing those meds to help get it under control, to properly manage the disease, and ensure that, overall healthcare is or the overall health is maintained long term, right? So this is capitation at its finest, right? Hey, this is all we're paying, and you're being reimbursed for the health of the patients. Okay, so okay, cool. But where does it maybe go wrong? Okay, so this is another study. This is from 2019. Yeah, 2019. And so Maryland capitated payments in some rural hospitals. And what they found was that the capped hospitals dramatically reduced their own activity. So less care for those patients. Like, so maybe on the front end, it's like, well, that's good, right? Like they stopped doing all the things that they were supposed to do, right? But what they found is that those patients actually sought more care at other hospitals because the way the capitation in this experiment worked, it didn't capitate payments, basically limit these payments at all hospitals, just some of the rural ones in Maryland as part of this experiment. And so those patients, if they couldn't get care at their rural hospital, they could drive into Baltimore and they could go to a hospital in Baltimore. And Medicare spending for patients at those hospitals actually increased because remember, this is under the sort of the state program. Under those patients who are covered under one of these plans, and not under not for Medicare patients who were their care was being paid for separately, and so Medicare was being charged more or billed more, which sort of maybe indicates sort of two things. That one, the patients were maybe not getting all the care that they wanted to, so they were forced or diverted to other hospitals. And two, maybe the hospital was like, okay, yep, we'll capitate our, we can't charge any more here, so we're going to charge for these other services. Bottom line is, like anything else, it can go wrong. It can be gamed. And you've got to have a good holistic view to make sure that we're, hitting all the endpoints we need to hit, and that there's not workarounds. This is where we get into the risk. So, rewards underservice. So that's where maybe hospitals were turning people away, and then they were forced to go to, another hospital to get the care that they needed. You're paid whether or not you deliver the care or not. So you are incentivized as a provider to provide as little care as possible. And so maybe you just add a little bit more friction to the appointment process. If people are 5 minutes late, you cancel them. I don't know what you do. Like, you can do a lot of stuff to not, provide care. On the flip side, it also incentivizes people, it also incentivizes systems to try and have people be healthy, right? And so if you have people who are on chronic meds, it incentivizes them to have, let's have a nurse phone call. Let's have a nurse make phone calls and like, hey, you haven't refilled your scripts. Could we set you up with a mail order pharmacy to make sure that you take your meds, right? That they won't get paid for that under fee for service necessarily, but that might be something they're willing to pay for under capitation. And a lot of this, the attitudes towards it, stem from the 90s, with the HMO backlash, the managed care backlash. People were saying like, oh, you're going to be forced to do like drive-through deliveries. You're not going to be able to, have to deliver your baby and won't get to stay in the hospital, all this stuff. And like, I will say like, I still sort of had that, perception a little bit. Cause like, it was very much like in the news when I grew up, and when our son was born, like I was like, oh, like I don't know how many days do we get in the hospital, and they wanted to keep him another day, and blah 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 blah, and then sort of like did the math and like dug into the paperwork and was like, oh, like we won't pay anything more. Like we've already paid our full, out of pocket max for the year. Him needing to stay in the hospital an extra night doesn't actually cost us anything more. So oh, okay. Like, but that like endured, like, and so people, it's still very much in their minds about like, oh, like they, you're to get the control the costs and all this stuff. And so people are really sort of nervous, I think, and averse to the idea that care is going to be limited by this. They resent the idea of restricted networks, prior authorization, like what you can do, what you can't do. This also, incentivizes, we talk a lot about what are the incentives and what are people incentivized to do. So this, this per member per month capitation, where you get a fixed fee for everybody. If you have a lot of sicker patients enroll, it's not going to be covered. And how do we see this play out? We see companies choosing to exit states. So insurance companies choosing to exit and not offer any plans in a state anymore if they basically determine that the patient population in that state that's enrolling in their plans are too sick to make any money on. You'll also see it, and we'll talk about Medicare Advantage. Medicare Advantage plans are very careful about who and where they advertise to. You want healthy people to sign up for your plans. You don't want sick people to sign up for your plans. So that's sort of a risk. And now there are like, well, how's that fair? How do you get around that? So it's like it's an arms race. So there's risk adjustment. Okay, so if you have sicker people, then okay, well, there's going to be some risk adjustment to adjust for the fact that this patient population is sicker than one in a different area. A rural agricultural town in California that it's a working class population. They have a hard life. They're working on the farms. They're exposed to a lot of chemicals and a lot of harsh environmental conditions. They're going to be, they face challenges that the upper class tech workers in San Francisco don't face. How do you adjust for that? Well, there's ways to adjust for that. But then, of course, then the insurance plans, they game the system and they make all of their patients look more sick. So it's this back and forth. How do we balance these things? So maybe capitation. We talked about that. Maybe that's not quite right. But so instead of capitation, another option, and some of these, it's not necessarily all or one. You can layer them. You can have different players sort of doing all of them at the same time. So this is sort of, I think, the big one right now is pay for performance. So you've already got the fee for service, especially with your standard Medicare, right? So we're not just going to throw out Medicare. So a lot of people on Medicare right now, right? So we aren't just going to dump that program, but they've added pay for performance. So layering quality incentives on top of that, right? And the idea here is let's link payment bonuses, or on the flip side, penalties, carrot and a stick, to quality metrics rather than just volume. Hey, if you do a ton of care, then, we better see some benefits for that, right? If you try and we're just not going to see anybody, all right, well, then people are going to have worse outcomes. There's a bunch of CMS programs, MIPS, Merit-Based Incentive Payment System, Hospital Readmissions Reduction Program. So, really big, trying to prevent hospital-acquired infections, CLABSI, that type of stuff. So you want people to leave the hospital healthy and not need to come back. Hospital value-based purchasing. So, you want, your quality scores. Overall, the evidence is mixed. And I attribute a lot of that to, one, imperfect metrics, and two, hospitals gaming the system. So we'll look at an example of that. So this is from a 2018 paper looking at one of those programs we mentioned, the Hospital Readmissions Reduction Program. In particular, they were looking at heart failure. So patients admitted for heart failure, they get treated, and then they're discharged, and you want them to stay discharged. They should leave the hospital healthy. Whatever you did, they should leave the hospital healthy. Okay. Now, we know that not everybody is going to leave the hospital healthy. All right. People are going to have to come back, but we'd like them to leave healthy and not come back too soon with an infection that they acquired in the hospital, right? Something like that. So the Hospital Readmissions Reduction Program provides for some penalties if you have basically too many patients get readmitted within 30 days. That 30-day cutoff is really relevant to this study. And so this study looked at hospitals and put them in two buckets. One, there were hospitals that had been penalized. Okay, so they got hit with a penalty for too many readmissions. And then you have non-penalized hospitals that they did not get hit with these penalties. And so, top of your mind, you should be like, well, the penalized hospital, they're clearly worse. They all their patients kept coming back after getting discharged for heart failure. This study just looked at heart failure. You can find plenty of other studies that find similar results, in other clinical contexts. But it's kind of interesting. So what they looked at the number of patients admitted for observation versus who were admitted as a readmission for their heart failure. Okay, and so we see these two lines here, or two sort of clusters. On the bottom one are the penalized hospitals. So these are hospitals that paid a penalty for too many readmissions, okay? And then up top in the teal are hospitals that didn't pay penalties. The y-axis represents the percentage of those heart failure patients who were readmitted. They were admitted as for observation status versus readmitted for their heart failure. And on the x-axis here is how many days from their discharge. And of course, that 30-day line, that's where CMS, Center for Medicaid and Medicare Services, is looking and judging you, okay? And so what we see is that a much higher percentage, so like around 11% on average versus like 15% on average, so like a 4% difference, or like, you know, it's like 4 percentage points, like 50% more, something like that, 40% more. It's a big difference. Non-penalized hospitals were saying, hey, no, we're just submitting them for observation, no big deal, just want to keep an eye on them, right? 15% of their heart failure patients, of the patients who'd had heart failure and were subsequently admitted, 15% they said the reason was observation, versus, you know, only 11% of the hospitals that ultimately were penalized. And then what you see here is that after that 30-day mark, those numbers go way down. Okay, so this means that 55 days after the discharge, if the patient is readmitted, they 92% of the time they say, yep, it's a readmission. Well, only 8% of the time they say it's for observation. And so, you know, what you should see is probably something like a consistently straight line, right? From like here all the way straight down, like, or maybe even like, you know, maybe even it's a lower line. Maybe it's like the whole line is lower. You know, you could sort of argue different ways, but you really should not see this sharp change in the slope right at the 30-day mark. What this tells us is that hospitals, both the ones that were penalized and the ones that weren't penalized, are, you know, saying, hey, you know, we're not admitting this patient for, you know, for readmission. We're just admitting them for observation, right? And hospitals that game that more, they don't pay the penalty, versus the ones that, you know, it's still going on, but to a lesser degree. So this is where these pay for performance plans, it's a good idea in theory. Whether or not it actually works, it's mixed. And you know, this relates to what's called Goodhart's law. So when a measure becomes a target, it ceases to be a good measure. And so thinking about, you know, hey, what percentage of patients get readmitted? If that's what we're focusing on, but people are able to choose whether or not to call this a readmission or admitting for observation, well, now our data is not accurately measuring what we think it's measuring, right? The financial impact of these plans. So looking at, you know, the broadly the accountable care organization model, where everything's sort of integrated and we want people thinking about all this care, and, you know, deciding what, you know, what does a patient need, making sure they get that. So they generated $2.8 billion of gross savings, and then that gets shared between the taxpayer, CMS, Medicare, Medicaid, and, or in this Medicare, CMS is Medicaid and Medicare, but in this case, we're just talking about Medicare plans. But only 317 million of that went back to Medicare, the taxpayer, after the shared savings payouts. You know, we can debate back and forth. Is that the right split? I don't know. You know, if you don't, it's one of those things. If you don't make it worth somebody's time, they're not going to do it. It's a hard thing. So let's talk about now. You know, we've talked about a lot of these different plans. Again, nothing is perfect. What do we want? Like, what do we actually want? Okay, and I'm going to deliberately bring us all the way back to 2008, to the triple aim. All right, so the idea, and let's start with care. Okay, so experience of care. You have a patient, they need something, right? Like, I have chest pain. Like, okay, like, yeah, you need your chest pain addressed. You want to be rapidly brought back to a cath lab and have your STEMI addressed, right? And then have good cardiac rehab, and ultimately, you know, have, you know, many years of healthy life after that. Or maybe it's something, you know, more benign, like you just have this really frustrating skin rash, that, you know, and you want to be able to see all the different folks that you need to see, and it's finally like the the derm PA is like, actually, you know what? I don't think this is a derm thing. I think you need to go talk to rheumatology, and then you talk to then get the rheumatology care that you need and get the right sometimes very expensive drugs to manage this condition, right? So people want that, right? They want their care paid for, and sometimes it's very expensive. We want population health. Okay, so this is sort of that broader view that healthcare generally, we often view it as just fixing things, like when they're broken. But that's too late a lot of times. How do we, obviously provide those things that we need, but also just more broadly, how do we be healthy? I cut it out in the interest of keeping this lecture shorter, and I know it's still going a little over an hour, because I know next week is a bear. But there's a great health economist, one of the sort of foundational work in health economics, by Grossman, that looks at basically the idea is that health is a capital stock. It's something that people they want to accrue, and why? So that they can get utility out of it and enjoy their life. And if you expand that to like the population, what do we want? Is we want to be healthy. We want to be healthy so that we can enjoy life. That's the bottom line, right? So how do we get a healthcare system that provides us that, and how do we make the payment systems support that, right? And then finally, we've got to be concerned about the per capita cost of care, right? Because somebody's got to pay for it at the end of the day. And if it's too expensive, it's just not going to happen. And that's where these incentives all tie together, and you can't disentangle one from the other, right? We can have incredible care and incredible population health. Like, we can make that happen today. It's going to come with a price tag. How do we manage these three things? And this is something you can also deal with at the at the system level, even within your own unit. Like, how do we manage these trade-offs? How do we handle these different things? How do we okay, we can, with a given level of experience for care, we can afford to take on a few more Medicaid patients, and you can advocate for that, right? With that, in order to provide population health. Hey, this is something that we should do that we can provide within the total scope of what we're doing. We can make sure that those things happen. Again, sort of going back to the postpartum example, I think lactation consultants in the hospital, that was something that my wife really, really appreciated, having a lactation consultant. And then we also had a lactation nurse. I'm trying to remember what her title was, but she had a certification and all this stuff, and came to the house like once or twice. And we had a copay for that, but it was very, very modest. No way our share covered that. Like, but why are those things worth covering? Because they help build this overall population health. And then from like a selfish point of view, the insurance company is probably like, there are some benefits both to mother and baby for this, and maybe it's going to reduce the total cost of care. So where can we get like wins on the triple bottom line? I think there are those wins, and then there are things where it's like, hey, you know what? This is going to increase per capita cost of care, but it's worth it. Okay, and so this is one of the readings for this week. I think it's a good one. It's mostly, and we'll talk about it in a second, it's mostly withstood the test of time. And I want to emphasize though, and why did I pick this older one? Because these are the same problems we've been debating for decades, and there's not an easy solution to a lot of this. The takeaway as leaders, as PA leaders, is you have to do the best you can with the reality that you're facing. You have to affect the things that you can affect. And one of the things that one of my friends sort of said this, and it was sort of like off the cuff, but I don't even remember what he was talking about. But he was talking to somebody who was sort of like being just like very idealistic and not willing to compromise at all if it wasn't going to be perfect. And he's like, look, do you want to be smug, or do you want to like mostly win? Like, you can have a small win. It's not going to be perfect, but you can take this win and keep working for the reality and the future that you want, or you can walk away with nothing, right? And so that's what I think we need to just be a little bit realistic and affect what we can affect today, affect the people that we can affect today, affect the scope of our influence, affect that, continue to advance, and work for more, but look for the wins that you can find. Now, the triple aim has since been expanded to it's less catchy. The quintuple aim includes healthcare workforce well-being. Obviously, a great, super important. My wife's a nurse. I was an EMT. My sister's a primary care physician. Like, I get it. Like, and I mean, we've all had experiences with patients and family members and healthcare administration where they're breathing down your neck, you're working insane hours, like all that stuff. Healthcare workforce well-being is critical, obviously, like for the people doing it, but also for the sustainability of the system, right? And same with health equity. Like, we can't have good population health unless we have health equity. All of these things, you can't have one without another, and there can be those tensions, right? And so that's where we have to be mindful of, oh well, what we could just, and I know this has come up in discussion posts in this class in the past, where certain hospital systems administrations have basically, due to financial pressures, they're making mandatory overtime for PAs, mandatory, ramping up the number of mandatory clinical hours. That could work in the short term to improve the experience of care for patients. It could, right? Well, now there are more appointment slots available, and now you're better able to see your primary care provider. That could be good for the patient, right? That could improve population health. That could, from the perspective of the system, they're able to bill more RVUs, and they're able to bring in more, more money. That's great. But if you burn out your PAs, where are you 6 months from now, right? It's not sustainable. So that's where it's a balance of how do you balance all of these things, and think through, okay, if we do this, what's the next step? What's the consequence? What's the second order effect? What's the third order effect of all these things? And so all these, as we're designing these systems, deciding how we respond to these different things, keeping these in context. And again, you can find stuff on the quintuple aim. I think it's all valuable, but I like the triple aim reading. The reading is a little shorter, but also just underscoring, like, these are problems that have been debated for decades. That's why I didn't go with the more recent quintuple aim articles. All right, so wrapped up this module. So we went from talking about volume and just, hey, pumping more patients through the system, doing as many services as you can provide, to ways that the system has tried to control costs a little bit and better tie the activities of healthcare delivery with population health. And then we sort of capped it all off by bringing in the idea of the quintuple aim, where you've got multiple things that you're trying to balance, and that sometimes these are in tension with one another. So in the next next and last part of the module, we will look at one particular policy in a little bit more detail, looking at the idea of Medicare Advantage plans and seeing how some of these tensions can play out. So see you in just a minute, and we'll pick it up from there.